Last year, Jess Jacobs, the Director of Innovation at Aetna, blogged about her care experience with two rare diseases. Jess is trained as a Green Belt Six Sigma, so she would write about a 12-hour wait in the emergency room as having a 7% process cycle efficiency. Over the course of a year, she documented 56 outpatient doctor visits, of which 29% were useful, 20 visits to the emergency room, and 54 days as an inpatient across 9 hospital admissions. Her calculations showed that only 0.08% of that time was actually spent treating her conditions. For her, time saved equates to quality. Speed is quality. And in healthcare, we deliver very little quality when defined by a metric that matters most to patients, patient time. So if we think about how we reframe thinking about quality and measuring quality, it forces us to become very patient-centered and even a little uncomfortable as doctors as we come up with innovative solutions to some of the most complex problems. Let me give you an example. How many days does it take for an average hip replacement required in the hospital? 3 days? 4 days? Well, for up to half of our patients at Kaiser Permanente, the answer can be a 0-day stay in the hospital. To achieve this requires extreme teaming with radical transparency on every step of the workflow. For example, anesthesiologists need to perform an anterior block, an anterior approach, as opposed to the other things that they do. This prevents the pain, but the patient can walk immediately off of the OR table. The needs of the patient come first, and the team. For the orthopedic surgeon, you're allowed 3 devices, small, medium, large, not the 8 that they like to pick from. The minor differences of one surgeon's preference to the next are subsumed to the greater good of standardized preference cards, standard workflows, and improved safety of nurses having to learn fewer devices, decreased infection rates. All of this works collectively at a population level to achieve amazing outcomes. Before the surgery happens, a pharmacist goes to the patient's home and explains any medication changes that are needed. Before the surgery happens, a nurse visits the patient's home, gets rid of that rug the patient can trip on, maybe gets grab bars installed in the shower. It teaches the patient and the family what to expect. Before the surgery happens, we deliver the right-sized walker or cane to the patient's home, not looking around in a closet for the cane on discharge. Maybe they move the bed to the ground floor. Maybe they do another few things in the home. On the day of the surgery, that hip replacement surgery is the first case of the morning. And after recovery, the patient walks 20 steps, goes straight home. Who's waiting at home? Physical therapy. The first PT appointment happens at home. And that evening, the surgeon calls and says, "Mrs. Jones, I'm not going to be able to sleep unless you can sleep tonight." Let me tell you, she sleeps very well. The next morning at 9 a.m., you can set your watch, physical therapy is in the home. At 10 a.m., a nurse visits the home. Both write up their notes in the electronic health record, and at noon, a physician reviews both notes. 3 p.m., physical therapy in the home again, and the next morning is an outpatient appointment with the surgeon. This is reliably excellent care with multiple safety nets in a psychologically safe environment where it's everyone's job to speak up and ensure that the patient's needs are being met and that the best outcomes are achieved. It's a flat hierarchy where team members are all responsible for ensuring safety. Pop quiz, what's the hospital-acquired infection rate with a 0-day stay? 0. What are the visiting hours like at home? Pretty good. The quality of the food at home? Pretty good, I hope. And the satisfaction scores that patients give their experience at home? Through the roof. How much quality time do we give back to Mrs. Jones, who can recover in the comfort of her own home, surrounded by her family, away from the constant din of the hospital? Let me set the record straight. Perhaps the most important thing to achieve these incredible patient-centered outcomes is standardization. But an important but unheralded part of the equation is customization or personalization. The mistake that we make over and over in medicine is that we usually start with the customization. Every patient is unique. Every patient has nuances that are meaningful. Yes, that's true. But let's start first with what's common, not with what's different. Let's start with templated workflows for the entire team and raise the standard to the top of the evidence-based hierarchy. If the physical therapist is not waiting for the patient at the patient's home after discharge, the whole system fails. If the surgeon fails to call the patient at home during her dinner, it fails to delight the patient, and we risk a return trip to the hospital to answer a simple question or two. Templates matter. Algorithms matter. They raise the bar and not actually reduce to the least common denominator. So on top of standardization, we add customization. Customization to the preferences and expectations of the patient and family, customization to the local needs of the surgical and clinical care teams. And as we customize, we never lose sight of the collective needs of the patient and the family and the care team. Those collective needs are line of sight to every team member, because with every optimization of a system somewhere, you run the risk of de-optimizing the system for someone else. Earlier, I spoke with you about Jess, whose calculations showed that less than 1/10 of 1% of the time she spent getting care was actually spent treating her condition. Last year, she spent 54 days, nearly 2 months of her life, waiting instead of healing. Maybe health systems should be rated on how much time they give back to patients like Jess, how many days at home per year they achieve for her. A tragic footnote about Jess. She died in August at the age of 29. She has no more time. So I hope that you believe, as I do, that speed is quality, that standardization is innovation, which allows for mass customization, and that we need to give patients more of what they want and need from us: time. Thank you.